Hi, everybody. This is Raji Amrus, CEO and founder of the San Diego Pain Summit. And on this portion of Clinical Mastery Pain Science, I'm here with Julie Wiebe, and she's giving us some of her time today for this discussion. And she has 20 years of experience in both sports medicine and pelvic health. Her passion is to turn women to fitness and sport after injury and pregnancy and equip pros to do the same. She advocates for the awareness of pelvic health issues in fitness and promotes innovative solutions for women through her blog, videos, and social media. She shares her evidence-based integrative approach internationally with both professionals and women through live and online educational programs. So welcome, Julie, and thank you so much for joining us here today.
Thanks for having me. I really appreciate it.
So, something that we often hear from clinicians, or I know I do, is that they interpret the term biopsychosocial to mean anything that's not related to a physical structure. So, so when you're working with, for example, you personally work with populations who are dealing with prolapse or incontinence with women, what is treating that group like when, from a biopsychosocial model, when you're treating structures, right? Or you're focusing on structures. So what would you say to clinicians who might be thinking, okay, biopsychosocial means something outside of treating structures? Or
that's a great question. I do treat a lot of prolapse and incontinence and diastasis, which are all very pregnancy and postpartum related, but I also do have patients who have pain, pelvic pain, musculoskeletal issues. But I think what's been interesting for me is, I've been doing this with this population. Most of my population wants to get back to fitness. But they are actually dealing with tons of fear around movement, and in particular fitness movements, because the way that a lot of the information has gotten out there around prolapse, incontinence, diastasis is movement bad, fitness bad, they created your problems in the first place, stop. Actually, my whole path was to start to try to create solutions for my patients in and around fitness, because the pelvic health, all I understood from pelvic health was stop, like that you should just stop exercising if you have a pelvic health consideration. So I have committed my career to trying to help them find paths back. So the biopsychosocial, for me, there is a structural piece for sure, but to understand that it's not only one structure. Most of those things have been solved in the past with just pelvic floor, but the reality is the pelvic floor has friends. So there's a lot of bio there. There's the diaphragm, there's the TA, there's glutes, there's lats, like all sorts of muscles help the pelvic floor do its job better. And the way we use the rest of those muscles impact how the pelvic floor works. So that's very bio. But in terms of the psychosocial, can social mean social media? Because that is become almost an enemy to creating what I like to call educated hope. So many of my patients are fearful because of what they've read online, and they think, if I go lift a weight, my organs are just going to fall out of me. If I'm not supposed to do any kind of plank or crunch because that's what the internet told me. And if I do that, I'm going to have a diastasis. It's been this battle of trying to help women exercise well and smart, but not make them so afraid that they won't move. So it's a real balance for me to try to help women see fitness as their path back to that. That's their rehabilitation for me, is using their fitness as opposed to eliminating it or making it remain dangerous or fearful to them. So that there's a real biopsychosocial. For me, fitness is as biopsychosocial as you can get. And so I like to use that with all of my patients because that's their goals. But it's part of that structure. There is bio there for sure. But a lot of it is just helping them have permission to move again and then gradually progressing. So, yeah.
Yeah. So, what would be, so if there's any pelvic health specialists listening or other clinicians who are interested, what does it look like when you have a patient come in and she's very scared of starting exercise and she's coming in because on a referral or whatever? What are some steps that you take to alleviate those fears from your experience that you can share with the clinicians who are listening?
Well, the part of what I do when I do my intakes is, because again, most of my patients are athletic. And so what I have found is that generally speaking, there's something that they're doing that isn't recreating the symptom. And so I ask them, can you identify 3 things that you're doing at the gym that don't aggravate the symptom? Whether that's pain, and for some people it's super low level. Like, I'm good in the morning and I'm walking around my house lifting laundry baskets, but in the afternoon, I'm in trouble. Or, which gives us some information, right, about what's creating the symptoms for them. But I asked them if it's something specific in an exercise program. What are 3 things specifically that you can still do without symptoms? Is it deadlifts? Is it squats? Like, what's still working for you? And then what are 3 things that you miss that either you've chosen not to participate in because someone on the internet told you not to, or you are not doing it because it actually aggravates things. So what I focus then on is the things they're doing with success. So to me, I call them my back doors. That's my back door into their brain. That's my back door into their joy. That's my back door into this activity that resonates with them. And the reality is that's the neuromuscular language that they're used to. Like, that's the neuromuscular language that they have become fluent in. And we need to be fluent in that language with them. Like, hey, like, this works for you. This is what you love to do. You want compliance. Get your patient continuing in the fitness that works for them. You may have to modify it a little bit. Maybe we're not going to run quite as far. Maybe we're not going to lift quite as heavy. But if those exercises are still good for you, let's keep you moving. And now let's look at what's bugging you here. Maybe we can find a thread through those 3 things that you mentioned. And then let's take a look at how you're doing them. And maybe we can start to piece together what keeps aggravating in those things. And maybe there's some commonality, and there usually is. Let's start to put together a solution within that. And so that's sort of where I like to start with my patients. Successful, struggling, let's keep doing this. Maybe make some modifications if we need to. And then let's look at what's here, because this is what they want. They don't want clamps on my table. You know what I mean? Like, this is the least used piece of equipment in my room. I want them moving. I want them up. And so we look at, and then they hear that I'm listening. Like, they hear that I'm listening to what it is that they have concerns about, what they're struggling with. Like, this is what we want to do. We don't want to be told, you can't do CrossFit anymore, or why don't you start yoga? Like, nobody wants that. They're going to listen either. So if I can, those are the paths that I start with to try to understand how to keep them moving in ways that work for them, and then start to kind of untangle what's up and what can we do there that keeps you moving, that either you can move without pain, that you can move without symptoms, pelvic health symptoms, and then let's start to eke into those boundaries and see what we can accomplish.
Yeah, and it sounds like, your patients are already pretty motivated when they come in, because I know, like, when I worked with athletes, of course, they're always, when can I get back to it? When can I get, whereas if somebody isn't already athletic, it may be more difficult, for them to think about movement and that sort of thing. So that's probably helpful that they're already kind of, motivated a little bit when they come in.
Like you said, it's a double-edged sword. Some of my patients are so motivated that, yeah, like they're like, hurry it up. Like, I want it. But what I have found is most of the patients that come to me, and I have all level of athlete, like, I really do. Like, I do, and I treat from low to high, and they basically need the same strategies. They just, like, for some woman who's lifting a laundry basket or the stroller, that's her max load. And I need to, like, her strategies around her max load look a lot like my CrossFitter who has a 300-pound max load, right? So it's sort of the same woman. They have the same motivations. They got to accomplish these things. But so it is a bit of a double-edged sword to be able to work with that mindset that wants to be at those high levels, and that level of motivation. But at the same time, you're right. I do have they want to get back to movement and fitness. But I have my share of patients that struggle with pain and can't move. And so my job is to find those back doors to help them find their way back to movement. So, yeah, but you make a great point. Like it does help a little bit.
I see. So you find that backdoor approach to even be more helpful with those who come in and who are like, okay, everything hurts. I can't do anything. That's what you use with that population as well.
Oh yeah. Yeah. I only have a few tricks. that's one of them. But yeah, and most of my patients, even if they've had like a long-standing issue, they do have like, even if their goal is I just want to walk around the block, then what I want to do is then also make their workout, whatever that looks like, their rehab, look like walking. Like if their goal is I want to get up a flight of steps so that and without pain or leaks or whatever it is, if that's their goal, my program better look like stairs. Mm-hmm. So I turn whatever their athletic activity is into, and whatever their challenge is, into their program. So fitness is one of the easiest ways to do that. And sometimes we pick something like, what could you do? You want to dance? Let's dance. Like what brings you joy? That's what we focus on. And if it's I've had all manner of patient and we choose whatever works. And, it doesn't have to look like athletics. It can be whatever it is that brings them joy, because that is my back door. If I can get someone like to do something they enjoy, I've got neuromuscular, that's the biopsychosocial, like they've got something that I can like navigate through to help get them moving again, even for a little bit. And then the brain's like, oh, cool, I can do this, get some success. Let's get some more success, like just to start to build on that. So yeah, so no, I use that approach for everybody, and I just choose whatever it is that works for them, for their brain, body, heart. Like what can we do that brings those together?
Yeah, and that seems to be a common thread with other people that have joined in this discussion on this Pain Summit Mastery, is that it's about finding out, rather than working from a specific formula, finding out what the patient enjoys doing and then working with that. So that seems to be a really common, and it's interesting thread, but it's unfortunate that it's not utilized more often in, clinical settings.
Yeah, we've kind of set up this system in physio and physical therapy to like, here's your carrot. You want to dance at your son's wedding? Okay, great. Here's your carrot, the dancing, but now let's go down and do like some bridges. You know what I mean? Like, let's keep dancing in mind. Let's do everything to music. Let's get you up. What can we do? And unfortunately, we have a very specific mindset on what that therapy is supposed to look like. And we've really focused, I think, too much on capacity in our world, in the rehabilitation world. Like, we can get you back to dancing at your son's wedding once you're at 5 out of 5 strength with your pelvic floor or your hip, no, your hip. That's a point. Hang on. Glute.
She is a specialist.
That's right. That's why the clinic is empty. We've made it like you have to get to this, like you have to be this tall to ride. But the reality is, if I can get you dancing, and then I'm going to build your capacity backwards. You know what I mean? Like, let me get you moving, and then I'll build the capacity. And so I think we've just spent a lot of time looking at capacity, and rather than looking like, how is she dancing? How is, what's happening when she's upright? Why can't she do that without discomfort? Like, so I look a lot at the strategies people are using on how they're accomplishing those things rather than eliminating them. Let's look at how they're doing them. How can we change that and keep them moving and get them off tables? Because nobody lives there. So yeah, they really don't. And pardon me?
Unless it's nap time.
Yes, exactly. Or massage time or whatever. There's some good reasons to get down there. But not if your goals have any, if you, again, whatever it is that you're looking to return to, we can break that down and create components that look like that inside your rehab, and your compliance is going to go through the roof. Patients, and this is what I found too, back to my double-edged sword with athletes. Sorry if I'm rambling, but they want,
ramble on.
Ramble on. But they if I've listened, like if I'm listening to their story, if I'm really listening and I'm like, listen, here's what I'm hearing. I'm hearing this consistent challenge with exercises that, you know, force you to do this or that, or whatever it is. I'm looking for that thread. If I've said that and I'm like, you know what? And I have a rule with my athletes and with all my patients, I usually find there's like 80% of things they can just continue to do. They don't aggravate. It's the 20. Like, what's our 20? And then if I've kept them doing the 80, and then I'm like, you know what? We keep trying to modify. We've done lots of changes with deadlifts or whatever it is. We just might need to back off those for a little bit. How do you feel about that? And for them, if I followed this whole path, like really listened, had dialogue, not directed, stop. Like nobody needs to hear that. They want to talk to you. They want a problem solver walking with them. If we've done all that, if at some point we've tried and we're just not getting anywhere, taking a little break might be the smartest thing we can do. And they're going to be willing to listen in a different way than if I'd started the conversation that way, right? Like if we've really worked at
You've
pardon me?
that therapeutic alliance with them so they can
100%. We're a team. Like, here's what I'm thinking. You can go, and I don't stop exercise. You can go back to the gym, but you got to be honest with me. If you're having symptoms, we got to back off. We got to change something. You know what I mean? So it's a team effort, you know? So, yeah. And which I learned because patients were like, yes, Julie, I'll stop running. And then they'd be like tying up their runners. They would run out of the clinic, you know what I mean? So it's like, how do we work together? And listening and having conversation is really how I do that. So yeah, but they usually are much more willing to back off of a couple things if you've made improvements, if they've heard you listening, if you're making their whole program look like deadlifts, they're going to be psyched. Yeah, I know I'm headed in the right direction. So, and they've also already been told no, you have to stop, just stop. Well, of course you have back pain, you're a CrossFitter. You know what I mean? Of course you're leaking, you play basketball, whatever it is, everything.
Yeah, it sounds like I just read a research paper that was shared on Twitter like a couple days ago, and it was talking about, of course I don't remember the title or the scientist, but it was talking about how patient-led goals are effective. It sounds like that's exactly what you're describing. You're letting the patient set the goal and work towards it rather than you saying, okay, this is what we're going to do. Like you said, you want to go to the dance? Okay, get on the table and let's get you on some wedges to get you to dance.
Yeah, that doesn't make sense. And here's the deal, it doesn't make sense to them either. Do you know what I mean? Mm-hmm. And it doesn't make sense to their brain. That's the other thing. Like what we're really hoping for from bridges and clams and whatever is carryover. But that strength doesn't carry over if there's no functional purpose to it. And if we think about something like we understand with Parkinson's, for example, with folks that have Parkinson's, you know, if we say get up, you know, sit to stand, we're going to do 10 sit to stands. But if they can't do it, but if we say, can you go get the door? They're up like that because there's meaning. And so for our brain, especially for an athlete or an athletic person, and again, I mean anywhere on that fitness continuum, it's saying, let's do 600 squats or whatever. I'm sorry, squats are functional, but what am I thinking of? Bridges. Let's do bridges. You know, let's do all these bridges, but now, and they want to go run. Like that doesn't necessarily, the brain doesn't know how to embed that. Like in order to get that carryover, why not do it upright in a lunge position in a way that actually at a speed that looks a little more like running? Like that, their brain's like, oh, I get this. And if you communicate with them, this is why I'm doing it. This is the part in your running cycle where I'm seeing some issues. I'd love for you to work on this. This is why we're doing it. Like that's speaking to the whole person versus we're going to do 800 bridges. Like it doesn't mean anything. And the brain can't like lock its teeth on it. So we're really speaking to their brain. We're talking their language. And it's also like, you know, a lot of athletes or athletic people give you a lot of resistance. You know what I mean? Like, well, I understand. I will do the bridges, but I don't like them. You know what I mean? You get all this resistance and they sound defensive or, you know, they won't stop, or we hear all these things about athletes, you know, but they're kind of defending something that's really critically important to them. This is their social life. It's their mental health. It's, it's something that makes them feel good about themselves. Like it's their relief of stress, all this stuff. And we've eliminated it. You have to just stop it. So yeah, so Therapeutic Alliance is just the perfect. Yeah, so we're there to help them.
Yeah, it reminds me of Dr. Peter Sullivan. He does a famous talk. You can find it on YouTube, where he talks about his patient who was scared to bend over because he thought his spines would collapse like the jelly donut thing. And
yeah.
But yet, if he sat on a table and bent over to touch his toes, that was no problem. And
right.
So O'Sullivan was like, that's the exact same position you would have if you were standing.
Right.
So it kind of reminded me of that, like get them to do some sort of movement. Like you said, they'll get up and answer the door, but they may not be able to just get up.
Yeah. Yeah. And it's really, it's a lot of, it's amazing when you're actually treating the brain versus that muscle. Like because the muscle doesn't work like that and the brain doesn't work like that. Like the brain is the boss here. And I think if we can treat the brain, that's where the beliefs are, that's where the emotions are, that's where, all of that stuff is, but that's where this neuromuscular, you have their neuromuscular history is in their sport. Like they chose it for a reason too. That's the other thing. Like my CrossFitters don't want to do yoga. My yogis don't want to do CrossFit. You know what I mean? Like there's something about it that resonates with them. And like, why not tap into that? It's fantastic. Like just modify what they're already doing. And you have their home program, you have their maintenance program, you have increased compliance. They're happy. You're the greatest PT in the world. It's pretty cool. So it's a lot and it's fun. I don't know. It's fun. So people are like, why don't you have exercises? Like, don't you have them all written out? Like, don't you? And I'm like, I draw ridiculous stick figures and the patient helps me write out the program at the end. Like, what did you learn today? What are we going to name that ridiculous exercise we did? How are we going to make this mean something to you? You know what I mean? And I do start every session with, okay, what are your goals? Why are you here today? Like, what is it that you want to accomplish today? This is what I'm hoping for. What are you hoping for? Let's make sure we're on the same page. But whatever they're hoping for is priority. So, and then we make sure at the end, do we get there? We get all that covered? Okay. So.
Yeah, it sounds like it takes a lot of creativity, from a clinical standpoint.
Yeah.
Like, would there be any tips or suggestions that you would have for anyone who maybe not feel so creative? Like, do you think if they take a look at what their activity is, as you said earlier, and then it sounds like you take a look at what they do during the day and you find out what they're doing that's not causing a problem, right? And just kind of start from there.
Yeah. Yeah. I'm actually not that creative. Actually, I think it shows in the sense that and this is the thing, I do not like formulas. Like if you do follow me on social media, that is one of the things that I am just like constantly hammering, please, let's think this more broadly. Like, how can we strategize around this? And I have patients like, I could just tell you some stories about me doing like crazy, people bring their exercise tapes in. Let's do it together. Like and I'll be like twerking and they're twerking, like whatever it is, it's actually like, I don't actually have to come up with anything. We just look at what they love. Like you show me, that's it, guys. Ask them to show you 3 things they can still do well, 3 things they can't do well that they're struggling with. Then this is where we're going to find our back doors and keep them successful, keep them moving. This I want you to keep doing, and maybe we'll boost that a little bit. And then these are the things. Let's break this down. What are we doing here that we can find some stuff to create some work around? So yeah, so I actually think I'm not very creative. I let them do all the work.
So you're actually like letting them bring in their exercise tapes.
Yeah. Oh, it's great. It's awesome. And and they'll bring a bar or they'll bring whatever it is. And that's the thing, like this really literally is my office. I don't really have a lot of equipment. And it's because I treat volleyball players and I treat, I do people who do Pilates, yoga, whatever it is, Afro-Caribbean dance. That was my favorite. I was like, why don't you show me? Like, I don't have a clue what that would look like. And so, and I don't pretend to know anything. Like I call CrossFit movements the wrong thing all the time because I just say, will you just show me what it is that you want to do? Okay, let's work on it. That's it. So it actually makes my job super easy. They bring me the issue, what they want to work on, and it's fun. Like, it's really fun. It's so much more fun because, they're like, can I try? Like, I haven't done a plank. I'm like, great, let's try it. And then if it works, we're great. Or maybe we have to modify it, or we might have to wait a couple weeks, or let's do it. Like, it's so fun to watch them be like, yes, I just did this thing that I haven't done for months. Like, it's just fun to watch that happen. So it's a lot of fun. It's a really fun way to treat.
Did you always work like this with patients, or?
Yeah. Did I always, or do I always?
Have you always worked like this with patients?
Oh, no. I wish. And I really, I'm trying through, I do teach courses. I'm trying to equip other professionals with this idea of sort of entering into therapeutic alliance and breaking down what they're doing. And one of my goals is I wish we could change PT education around this. Like, I just think, so no, I was this has evolved for me over a lot of years. But I treated like this for a long time. But, I was a new grad once.
How did that process look? Like, so, like, how would that, because, especially if there's any clinicians who are listening and they're like, okay, that sounds good, but it sounds so far out from what my training was like. Like, how do I get from there to here? And I know everybody's process is different, but kind of what was that like for you getting to the point?
Yeah. So, but basically,
it's an easy question.
How much time do we have? Here's the deal. I was sports medicine PT. That's my background. And so I've always worked with athletic folk. I was athletic. I'd like to still think I'm sort of athletic. So basically, it was after my daughter was born that I started looking into pelvic health stuff, mainly because I was struggling to recover. And I actually didn't have any specific pelvic health related, like what we would consider pelvic health issues when she was born. So she's 16 now. And again, like I said, I started trying to understand pregnancy and postpartum more and pelvic health. And that was when the core was new, you know what I mean? And so I started, because there used to not be a core, for those of you.
Yeah, I remember the core.
Okay, coming onto the scene. So anyway, but I really started trying to understand that for me. And then I realized how many of my patients were actually demonstrating similar patterns to me as a brand new mom. And so I started trying to apply my sports medicine-y side to the pelvic health side. And the reality is, like I said, back then, there was no solutions. Like, if you wanted to do fitness, but you had a pelvic health problem, your career is over. Like, there is no, but my patients wouldn't. And I wanted to be fit again. Like, I totally understood that passion. So here's the deal. The honest answer is there were no paths. And this was the path that I started to pull together over the years of because then I started seeing more variety of athletes who are having these problems. There aren't, back then especially, weren't a lot of practitioners who were willing to help women get back to fitness. Like, I was walking a tightrope, quite frankly, and it took a long time for these concepts and these ideas and for fitness to be acceptable and actually promoted now. Like, this has come full circle, but it literally was this path of okay, let's see, how can I apply these ideas that I know need to happen for this postpartum woman inside CrossFit? Like, CrossFit didn't used to exist. You know what I mean? Like, I got thrown some lobs from runners and I got some lobs from Pilates people, but then I had to start answering these questions for CrossFitters. So it really came down, and there's 8,000 CrossFit moves or something. So I can't treat all of those things. So it started to become really easy to be okay, show me 3 things you can't do. And I don't know all the yoga. I love yoga, but I'm a terrible yogi. I want to be an awesome yogi, but I'm not. But I don't know all the yoga moves. I don't know all the Pilates moves.
You don't know all the names?
I don't know all the names, which is partly what's intimidating for people when they look at CrossFit or they look at these things. They think they can't speak into it. But physios, PTs are supposed to be great movement evaluators. That's really what we're supposed to be able to do. And
I know Shavasana.
What's that?
Shavasana.
You want me to show you one?
No. I know what that is when you just lay down.
Oh, right.
That's
Yeah,
the only one
I'm
I
really
remember.
good at that one. Yeah, but again, see, I can't remember all the names. But the reality is, so because I see such a variety, I didn't know. I would be like, why don't you just show me? What does it look like when you go to yoga? Like, so that's sort of how it evolved, because there weren't a lot of practitioners that had this dual skill set. And so I sort of kind of helped create my own specialty. And this, that because there just weren't a lot of people doing any kind of fitness work or sports medicine type work for postpartum or pregnant ladies. So that was sort of the path. And that's kind of what I teach. So I've made all the mistakes for you. And you can skip all that crap and learn. But it does boil down for me to some really simple principles, and it's a really fun way to treat. Like, it really is.
So when you're teaching your workshops, what's the biggest kind of wall that you come up against when you're teaching a workshop of clinicians about what you're doing?
So that's a really interesting question, because it's really evolved over time. Like I said, initially with pelvic health providers, I was, what's a nice word? I was kind of a blasphemer a little bit. And that's changed a ton, like no hard feelings at all. But in sports medicine, like, the idea that they should care about pelvic health is also new, right? But that's also changed. Like, like, we are starting to see more and more stuff about female athletes specifically. It's fantastic. And if you're going to treat a female in your clinic and they want to do any measure of fitness, you are treating their pregnancy history, their postpartum lingering issues, their pelvic health. You are treating those things when you're doing their shoulder, like, whether you like it or not. That pelvic floor is a part of that system, and you got to know what's happening down there. So that's been a huge push for me, to try to bring everybody to the middle. So the resistances are different, but they've changed a ton over time. So that people they really are starting to, I think as a profession, as a world, we're starting to look more holistically. Like, I think the biopsychosocial model has started to help us all be like, maybe we need to kind of reconsider sort of some of these old held principles, and people are more looking to be more holistic in their practices. So I don't know, like, now I'm trying to think what exactly.
Currently, you're not really seeing that currently with your students.
Say that. I'm sorry, I missed the first.
Not seeing that currently. So currently, you're not really noticing.
It still happens. Mm-hmm. Both of those things still happen, but at this point, folks are coming because they're seeking it out. Like, it used to be that people were, I've had crazy things happen at courses. Like, you can feel the resistance in the room. And then by day 2, we're friends. You know what I mean? Mm-hmm. Like, I've been through it all. I've had people jump up in the back and point at me and, why are you contradicting yourself? Like, it's hard. Like, we're all having to live in a new gray middle. And we're trying to figure out, like, how do we actually apply all of this change? And for me, it's really always been my focus, is the neuromuscular, strategy-based, systems-based work. And so just honing in on how the best ways to apply that has been my solution. And I understand, like, we got to find our way to the middle. I think the middle is where probably the right answers are. But, we get into these, like, battles, no structure, no pain science, you know what I mean? Like, somewhere in the middle, like, if both of those things hold some truth, like, where can we find our middle ground? You know what I mean? Like, so I've just tried to walk the middle, and, and again, it's changed a lot, which I'm so grateful for. Like,
and I think it has to go to one extreme to the other before we could even find that middle ground. But that's why, people like clinicians who are educating, such as yourself and others, I think you guys are doing a really good job of helping show people, because the biggest question is, like, how does this information, so right now the best model we have is the biopsychosocial model. Mm-hmm. Until something better comes along, but how do we use that, so that's what, educators like yourself seems like you're doing a really good job at helping clinicians understand how to make that transition.
Right. Yeah. And it's funny because to me, fitness is an amazing biopsychosocial modality. Like, it's incredible. And so it's kind of cool to sort of see the incredible power that it has. And then to share that with other clinicians. Like, we can do that. Like, we can start to make this look super cool. And you know what I mean? Like, we can, and it also can fit into old, like, you can, you know, sometimes you do need to do some straight up strengthening. Like, I get it. You know what I mean? Like, sometimes you have to do that stuff, but yeah, I'm trying.
Well, especially with all that research that's coming out about how important it is for movement, like, it was once assumed that exercise helped you lose a lot of weight. And now it's like, well, it's not really that so much, but our brains crave that movement. And, so it seems like this is a really good combination.
Yeah, well, I hope so. Like, I love treating this way. It's so fun. And yeah, and I think it's fun for the patients too. Yeah. Yeah. Thanks. I'm right there with you. I agree. It's cool.
So, if you're talking, because I noticed, I was reading through some of your blog posts and stuff, and I was noticing how you were talking about, and in particular in this discussion as well, the fear that people have around movement, especially with postpartum issues and that sort of thing. What are some ways that we can alleviate that fear in other clinicians? So if there's, as opposed to just the patient themselves, which if they're coming in to see you and you start that therapeutic alliance, but then what about with our colleagues that we may be working with?
Yeah, that is really a great question. It comes like at some point, rehab was very protective. Like, I think that's how we were all trained. Injury prevention, and again, we were taught to focus on capacity. Do they have the range of motion to do that activity? Do they have the strength to do that activity? And, I would love to go back so many of my patients and do something different than I did way back in the day. But we didn't have anything else. We didn't have any other options. And so it's tricky because I think that people do not understand the power that they have in people's lives. Like, they really don't understand, especially like when they're on social media and they have large followings or whatever, like they really are, they have authority in people's lives and they don't understand that authority. Me too. Like, I sometimes say things and I'm like, ooh, that was probably a bad choice of words. You know what I mean? And we're all learning, right? We're all trying to do better. But I think that we need to somehow change our educational model around that protective mindset and move into the progressive. Like, that one of the things I talk about is protection versus progression. Like, how do we, because a lot of my women, and again, I do have an athletic population, but they come to me after they've seen other clinicians, let's say for a diastasis, which is the separation of the abdominals. And, they maybe didn't make progress or they got discharged for whatever reason. And they were told that they were a surgical candidate because they can't get their fascia going or they can't, get the tummy moving the way they could before. But they were never, ever challenged. Like, there was never enough stimulation provided. Like, because low level didn't kick it up, the assumption was they wouldn't be able to tolerate higher level. But the reality is, when I give them a kettlebell and ask them to do a crunch, then I get it. Do you know what I mean? And I'm like, okay, your brain needs more, not less. And then we can really stimulate this to start working. Let's get it moving. You know what I mean? And so that is like music to their ears, but it's how we've been trained. So
that's a tough.
So it's really tough, but I'm actually working on my doctorate, trying to go back in. I'm going to go back to the beginning and see if we can get into some of these DPT programs and change that trajectory a little bit, because I don't want to see you 10 years out at my continuing education course. I don't want you to have my regrets over the people that I wish I had done something different with. Mm-hmm. Like, we can start doing something now that looks so different than the way that we've been trained. Like, I have students that come and watch me and I'm like, please don't tell your professor I don't use goniometers. I don't manual muscle test. I know, I announced it. I confess.
It's been recorded now.
I know, now I'm in trouble. because like at the end of the day, I mean, listen, I don't see total joint replacements. I don't have a population where it matters that much anymore. But I don't do manual muscle testing. Like me telling you have a 3 out of 5, that's not encouraging. Can you move? Can you squat? Can you get out of a chair? That tells me more about what your capacity is than 3 out of 5. Me testing that. So anyway, yeah, so I think we have a lot of work to do, but we also need to have more conversations with physicians. A lot of my patients come with really brutal messages that they've received from their physicians. I know there's plenty of physicians out there that are doing better, but yeah, it's pretty hard. And that's a huge authority in their ear, in their brain, in their heart. They're already convinced they need surgery. Those are the folks I have the hardest time helping.
And I think that's part of their training too.
100%.
I was watching it was a live symposium about the opioid crisis, and there was President Bill Clinton was there, and they had a couple physicians. One woman had been trained at Harvard, and I think she was maybe a recent graduate, 5 to 8 years graduate. I can't recall. And she said that in her training, in her medical training, they only got like 20 hours of pain education.
Yeah.
So that's a big problem too, and kind of out of our control as clinicians.
Yeah, but I mean, and I've had physicians reach out, and we started to have good conversations, and and again, like the understanding too, for me, for a lot of my patients who come to see me, they often do come to see me for something pelvic health related first, and oh, by the way, my knee hurts. Do you know what I mean? Oh, and by the way, I have back pain. But all I really am here for is because I want to exercise again, and it's my leaking that's stopping me from exercise, not the pain. And that's not always true, but that is some scenarios. And then once we start moving again, the other stuff kind of goes away. You know what I mean? And we do guide the movement. We make choices. We have new strategies. We change the load. Like there are things that we do in that. But, like we created these really, and it's just fascinating. Like I could tell you lots of stories, but even today I went to this exercise class with my daughter, and like the things the trainer was saying was like, where is this coming from? You know what I mean? So that might be the authority in this person's life. Like, oh, my trainer said I have to do it like this. And I kept modifying for an injury. I fell snowboarding, and she kept coming over. And I finally was like,
I've had that happen to me too before. And they're like, well, why? You need to do it this way. I can't really do it this way. Actually, it was when I was seeing a chiropractor, and it was way back then, and the yoga instructor wanted me to do something that my chiropractor had asked me to just not do. Who knows whether it was right or wrong.
Right. Back in the day,
the yoga instructor looked at me and went, does your chiropractor understand yoga?
Yeah.
And I saw it coming, and I was like, do you understand chiropractic?
Good for you.
And two of the people sitting next to me on their mats, they like kind of moved away from me.
Well, the interesting thing is the trainer and I was modifying a couple other things, and she kept yelling at me to stop modifying. And this is what I tell my patients all the time. You go talk to the trainer and let them know here, like, because I listen, I want to hang out with my kid. My 16-year-old wanted me to go with her to an exercise class. I will go whether the shoulder hurts or not. Do you know what I mean? Like, I just want to be with her and have fun and move my body. It was awesome. But I just kept getting yelled at. And finally I made a face. I know I made a face because I was like, all right. And she was spewing pseudoscience the whole time. Anyway, and so I made a face, and she started talking about how, people pay me a lot of money, and I know what I'm doing and all this. And then she said, and I kick people out of my class. And I'm like, oh, please kick me out of your class. I would love it. Kick me out because I sumoed my deadlift to help me with some low back stuff. Like, please, I would love for that to happen. Do you know what I mean? So anyway, but of course my daughter would be like horrified if I got kicked out. So, and I was just like, I'm smiling, I'm happy. I just want to move my body and be with my kid. You know what I mean? So I think too, we need to understand people's goals for being a part of exercise.
And that language, which is probably why you were able to respond. You didn't get on the defensive with the trainer because you already understand it is about the language that we use, and you just don't know that yet.
Yeah. Well, of course she doesn't. I mean, this takes forever. I mean, we know the MDs are still working it out. Like, it takes forever to trickle all the way down. And I don't mean down. I just mean, like, for all of this information, and please forgive me, that was not my intention. But, like, you know, for us to get this information, PTs don't know it. Like, so there was no hard feelings. It was just funny. Like, and finally I was like, I'm physical therapy. Like, I do not want to identify that I know anything. I just want her to let me not have to, like, do crap with my shoulder that hurts, so, but I get to move. Like, let me move. I'm having fun. So
be with your daughter.
What's that?
Be with your daughter.
Yeah, seriously, people. 16-year-old wants to go exercise with me. I'm in. I'll do whatever you want. What's that?
That's rare, huh?
I know.
Those hormones start kicking in.
I know. She's a gem. So anyway, but yeah, and her form, of course, is great. But anyway.
So for the clinicians who are listening, whether they're listening on their break and they're going back to work with their next patient, or it's a weekend, what is something that they can take from this discussion with them and maybe start using with their next patient that they see?
Well, I think start, like, honestly, that 3 and 3, it's a great tool. And find out what it is. Why are you here? I mean, people are there to get rid of their pain, but they're there to get rid of the pain for something, right? Like, whatever that something is, that's what we're treating. Like, that's what we're trying to get them back to. And really, so whatever that is, your job is to break that down and find out what, like, if you can, something, and again, it may just be something simple, like walking around the block. Like, why are we here? Like, getting rid of pain or incontinence or prolapse, like, they're like, the end game is what the brain wants. Like, that's what it's headed for. So making it meaningful to them around that goal. And it's really a fun way to treat. So, and we already asked about goals, and so just starting to break down and make components of it that look like that. And that's really sports medicine. Like, I didn't come up with that. Like, let's be honest, that's sports specificity. Like, I would give you soccer drills if you wanted to go play soccer. So this isn't like I'm some kind of genius. Like, I'm not. Like, this is sports this is what you do in sports medicine, but we don't always apply that idea, particularly in pelvic health, and we don't apply that in orthopedics. Like, it's just, so it's really a kind of a different way of approaching things. So that would be my suggestion. Be creative, like, have fun. Get in there.
Well, that sounds great. Well, thank you so much for joining us today, Julie,
my pleasure.
Sharing your wisdom and thoughts. And I really appreciate it.
Well, thank you so much for having me. This was fun. I really appreciate it. It's fun.